For me, I have to say I want to thank our speakers for today because they've really been exceptional and they've covered so much ground. It's always amazing to me to come to a meeting where I think I know something about the topic and walk away realizing that I have a lot to learn. And I've learned a great deal today, but that these issues are so complex and so deep and cover so many aspects of so many people's lives. So this has really been a great day for me, and I think I hope for everybody. And we're going to bring it home by returning to the front lines. The case managers were identified as the people who really are doing this on a day-to-day basis. And also, as angels, it's an honor for me as a mere mortal to be up here with the three angels. Very much a mere mortal. So I think one of the things I wanted to do is to spend just a few minutes just talking a little bit about what the case managers actually do. First of all, this is Tammy Neese, Beth Scott, and Wendy Kurtz. And they are all case manager 3s, is that correct? Yes. I want to get that right, at PAF in Hampton. And they do this on a day-to-day basis. But I'm not sure whether people really understand what this is. So I just wanted to spend a couple minutes just saying to you, Tammy, tell me about what you do on a day-to-day basis. Who calls you? Who are the people that are on the other end of the phone?
Well, in general, our mission, it's to help with insurance issues, debt crisis, and access to care. However, under all that, there's just a phenomenal amount of issues that we handle between uninsured and underinsured issues and appeals and coding and billing issues, looking for resources for rent and household issues and so on, Medicare, Medicaid issues, disability, employment, just a whole gamut of things. And we get calls across the country. We're national, of course. And patients call for financial assistance and they're scared. They have a lot of fear. They've just been diagnosed with a cancer or another disease. So they're looking for everything. And sometimes they call and they're not even sure what they're wanting. They're just like, well, what do you offer? What can you do for me? And then we explain what we can do. But they're calling for help, hope, someone to listen to. And I think listening is very, very important because that's where we find out what's the root of their cause, or their calls. Sometimes, they call for, well, I think I need help with my rent, or the insurance denied this, but there's also that and a multitude of other things as well.
Beth, I think sometimes when people think about what you do, they might be sort of envisioning, the airline customer service representative, the one and off kind of thing. But talk a little bit about kind of the extent of the interactions that you have with the people who call you. I mean, how you kind of get involved in actually really working out some of these issues that Tammy just described.
Well, I mean, just like she said, patients call and they originally call because maybe something is denied, a medication, a test. But come to find out, it's more than just that. It's, maybe the clinical trial was denied, maybe it's in a different state, maybe they can't get there, so, there's a transportation issue. Who's going to watch my child when I go have my cancer treatment? My husband, he can't quit his job, he can't go with me. So we have to kind of address all of those issues when somebody calls in.
And that's not a one-time thing, right?
Oh, no. I mean, sometimes our contacts with patients, they've done a little bit of study of if we do appeals. So we work on all the appeals basically that comes in through PAF, and sometimes we contact those people hundreds of times along with the insurance company. So sometimes there's hours on the phone with insurance companies and physicians' offices and faxing and receiving documents and reviewing those documents and writing appeals. So it's a lot of. So we do spend a lot of time on the phone with those patients, so that I think they feel very comfortable with us. By the time that we get finished working with them, they feel very comfortable telling us everything that they may not even tell their doctor.
Wendy, we've talked a lot about gaps today, gaps in access, gaps in understanding. How do you as case managers really help to bridge some of those gaps? How do you help people understand what is possible and what they should, even the questions they should be asking?
A lot of it's education. A lot of, patients don't know. A lot of patients don't know that there's such a thing as genetic or genomic testing.
Oh, yeah, and we're going to get to that.
Right. So a lot of it is education, finding out what their goals, their treatment goals are, their goals for, I don't want to say goals for life in a life coaching sense, but ultimately where they want to be in a year and 2 years. You know, a lot of people don't feel comfortable questioning their doctor, recommending or asking questions of their doctor as far as clinical trials and alternative treatments, or maybe some commercial they saw on TV for a specialized center. And a lot of what we do is making sure that they know those options are there. We don't necessarily recommend anything. Well, we don't recommend anything. Letting them ask questions that they have regarding, you know, maybe what their insurance covers, what it doesn't cover, going over with them. And, you know, some people are very hesitant because they think, okay, my insurance is not going to cover it, so why even try?
But you'll actually get on the phone with the
Absolutely.
doctor or the insurance company and really
Absolutely.
kind of bridge those gaps in a very,
Absolutely.
very tangible way.
Absolutely.
So now talking a little bit about the genetics and genomics testing, have you noticed an increase in people calling about these issues? Any of you, if you found that there are more people calling and asking about genetics testing or testing for their tumor?
Well, sometimes I don't think it's a huge increase, but and partly with the personalized care line, we're trying to promote that to get patients to call and educate. You know, for everyone that we talk to, the doctor's offices, we're really trying to educate as we're working with that for the appeals. But I feel sometimes there's an increase in people wanting to know about it. So it might be mentioned to them, but they don't understand it. And there's that lack of education on what does it really involve? What is it going to do to help me? And they might just say, well, not gonna worry about this.
Right, my doctor didn't offer it, so
Right,
I'm not
right.
gonna ask.
So I'm not gonna worry about it.
Right.
So I think these are very complex issues. I mean, you know, what's the difference between genetics testing and genomics, and when do you get this, and who gets it, and how do you access it, and all these different things. How do you kind of address this issue of just understanding the basics, even the language that's used? When did you?
Well, it really depends on the circumstance, on the patient. You really have to read maybe a patient's what you perceive to be their comprehension level. So it really is. I mean, and we all handle things different ways. You know, we all have our own style and how we approach patients, and I think it's more of an individualized patient.
Agree. Yeah, I agree.
How you address it with them. You know, and some patients you talk to them, they're really gonna want to hear it more from their doctor than they are us. So, you know, in that case, maybe we'd call with them to their doctor, set up an appointment, let them know that they're interested in talking about genetics or genomic testing.
So you'll actually call the doctor and let the doctor know that the patient.
Yeah, we do a conference call so that we're all in one call, and let them, you know, us kind of guide the questions.
Right.
So we want them to make them advocates for themselves later, to try to teach them whether it's insurance or anything like that. So, you know, if we can guide them of how to ask the questions, and maybe later and something else comes up, they can do it themselves.
So I don't want to put you on the spot, except I kind of do. But let's say you have a patient who's been diagnosed with a non-small cell lung cancer and doesn't seem to know anything about the possibility of having that tumor tested. Would you, I know you don't recommend things, but would you actually bring up the possibility that this is something they could ask their doctors about?
I think usually we ask, have you had genomic testing? And some will say yes. Some will say, what is that? And so then that kind of leads into, and listening to them, listening to the patient's story.
Right.
Also, we're picking up other aspects of the issue that they're calling, and then we can hone in on some of those other things too, because they want to tell their story.
Right.
So as we're listening, I've always been a note taker. I can type in it, but I also write down things faster too. So as they're talking, then I'm picking up other things, and I'll try to go back and find out that there's a lot more that they're calling for, but we do. And we'll call. We say, well, let's call your doctor's office. You know, let's talk to the nurse or the MA or whoever. You know, and let's let them know what you're feeling and what you want. At least put it out there.
So Mark just talked about the remarkably, in my mind, low rates of people taking advantage of BRCA testing or other kinds of genetic testing. Do you encounter resistance when you ask people about this? Do people say, I don't want to do that, or I don't know what that is, but I don't think it's for me? I mean, what kind of pushback do you get from the people you talk to?
I think the most common one is I don't want to know. I'd rather not know. I mean, I've encountered that personally in my own family. You know, I have my mother and her 4 sisters are all survivors of breast cancer. They're all BRCA2 positive, and you know, we have siblings that don't want to get tested because they'd rather not know. And I think that's the biggest, might be the biggest resistance we see. Is that I'd rather just live my life.
Right, and what do we do with the results once we know? I mean, is there something out there? Will my insurance cover that? Once we do know, will it cover my treatment? Or is it something else for them, some other hurdle for them to jump if they
Am I going to choose to have that prophylactic treatment? You know, is that...
So for some people, it's just opening a big can of worms that they just don't want to have to deal with.
But on the other hand, there are some that are, I want to know everything.
Right.
I want to know every detail so I can deal with this and take care of my family. So you have both.
Right.
Do you find any sort of noticeable differences between the people who really want to know and the people who just don't want to know? I mean, can you sort of pick out some characteristics? I mean, is it older people, or is it people from, I mean, that just are kind of more afraid of or resistant to doing this, or is that just hard to know?
Well, I've seen a little bit of both. I mean, I think older people, really older people, 90s.
How do you define that?
Or some of their families, they're like, no, they're not going to want to do that. You know, they're 80 or in their 80s or 90s, and they're like, they're old school. They're not going to want to do that. But on the other hand, again, the families are saying, well, yes, let's do that. We've heard about this. So I've seen a little bit of both. So education really needs.
And Candace had mentioned that one motivation for people doing it is really, if they don't help themselves, they help their children or their future generations. Do you hear that?
Yes, and we try to, I mean, at least I try to tell them, if you get that testing, then somebody else in your family is going to benefit from it. Maybe it not be you, like we've heard today over and over. It may be somebody else. It may be your daughter or your son, you know, and I try to let them know that.
We also talked a little bit or a lot about research and clinical trials, which is always a topic of great interest. I mean, this is something I've been working on for decades, trying to sort of understand how to get people more interested in clinical trials and not understanding why they're not more interested. But here's an area in this whole genetics and genomics research where there's a tremendous amount of new work going on. So how do you talk to people about maybe getting involved with a clinical trial or getting involved with a research study? Wendy?
It's kind of a tricky one when it comes to clinical trials. Because one thing I never want to do is kind of give them false hope or tell them, you know, here's this possibility for you at this facility when we have no idea if they're going to be a candidate or, you know, just on first glance, because the inclusion criteria is so specific. Sometimes, you know, especially if a patient has tried and failed at least 1 or 2 treatments, we'll have the discussion. Have you talked to your doctor about clinical trials? Do you know what clinical trials are? Kind of go that route, kind of educating them on what they are. And sometimes they'll want to, you know, call and find out what's available in their state or in their network. Sometimes they want to call their doctor, and we're more than happy to, you know, facilitate those conversations with their provider.
Do you find people are concerned about being a research subject? Or, I mean, that's always comes up as an issue, but
I haven't encountered that, but
I have.
know
I mean,
that
older people, like Tammy was saying, I would say even middle-aged to older people feel like, you know, they feel like it's still an experiment. They don't want to be part of an experiment. They want to know what real results are. And it's sometimes hard for us when they say they want a clinical trial because we won't know their whole treatment history.
Right.
And even the patients don't know everything they've been treated with. So when we're looking at trials, we don't have all of that information.
Then I tell them, I don't know, you do too, we can look for a trial, we can send you several, print them out, send them to you, or send you links, but take it to your doctor to have them review it to see if you're a candidate, because we don't know your complete history. So.
well, I think it's very hard for even patients to know their complete history.
Right.
Exactly.
This kind of thing.
Exactly.
I worked years ago in my consulting days with a very, very good community oncologist, and his view was, if my patients are interested in clinical trials, they'll ask me about it. He didn't see it as his responsibility to raise that issue. And so, I mean, it seems like another gap of sorts that, you know, you try to encourage patients to bring these issues up without knowing fully whether it's the right thing for them or what is the right thing. And then having doctors say, oh, well, you know, if they're interested, they'll ask me about it. So how do you encourage patients to have those discussions? I mean, to become proactive about it? I mean, even if they don't know exactly, just to say, is there a possibility that there's a trial that might be available to me?
Well, and I try to educate in general. I'll say, you know your body. That's been mentioned on some of the videos about you know your own body. So talk to your doctor or your medical professional about what you feel is going on. And if they're not listening and you're not getting the results you feel you should, the second opinions, which we help a lot with second opinions as well. And we really are encouraging, you know, to talk to them, write down your questions, and just discuss this with them. And we get both. That's helpful. And then we get some patients that say they just won't listen. They won't talk to me.
Right.
And I think, as Candace brought up about Medicaid, I encounter that, where we'll get calls where patients say, well, they're not giving me good treatment. They're not giving me treatment at all. They won't listen to me or talk to me because I've Medicaid or whatever kind of insurance. But generally, it seems like it's Medicaid. So there's a lot of coaching and really trying to conference call with them to their providers to, you know, say, well, this patient is interested in this, this, and this, or have you all looked into this? And, you know, have you gotten that prior authorization for this treatment or medication? If not, would you please do that? So if you get a denial, we can help the appeal.
And then they say, well, we're not going to submit an authorization because we know their insurance doesn't cover it. What's the use? Why would we do that? Why would we waste our time submitting an authorization when we know it's going to be denied? We try to talk to the doctor's office. Yes, you need to do that. That's the only way to move forward, to see if we can do an appeal or to see if we can get them to change it.
So people do just run into these brick walls, as you're saying. And you're saying that with sort of the right kind of intervention and the right kind of persistence, it is possible to sometimes either go over, under, or around the brick wall.
Right.
So
Sometimes we have to go through it.
straight through it, just knock it down. But that's really hard for people. I mean, I mean, even people that are highly educated and have good insurance, when they run into these brick walls, tend to say, well, you know, I guess that's that. I don't think that people understand that they really do have, that there's something they can do, that you can fight. And it's hard to fight because it's hard to get a hold of anybody that you can actually talk to and can make a decision.
Sometimes I think there's a lot of stall tactics, a lot of barriers with the insurance companies, so they don't have to cover or don't have to pay. And I'm maybe incorrect, but it seems that way. So we call, and we can be on the phone for 2 hours with the insurance company because we've submitted an appeal and they can't find it.
Normally.
Or they've lost
so
it.
Is it or they've lost it, or one person can find it in their system, but then we call again and they say, oh, it's pending, and we call again and they can't find it. So that's a huge barrier to try to get things covered sometimes.
And are you finding that this barrier is more or less the same with the genomic testing, or that it's
I
targeted?
think it's an appeal in general.
Any kind of, yeah, agreed.
Do you run into the issue of off-label?
Oh,
All
yes.
the time.
Okay, so tell us a little bit about that. I mean, I'm sure most patients going into a situation have never even heard of such a thing as an off-label drug. So tell me a little bit about how that kind of happens. Like, if you're a patient, how do you find out that there might be something like that available to you?
As far as the appeal or getting prescribed the medication?
Well, just even, that there might even be something like that, and then.
So typically by the time we see patients, they've already had genomic testing and, it's come back with a specific mutation that's found to be responsive to certain off-label medications. So by the time we see patients, they're usually already at the appeal stage. They've already received 1 or 2 or 3 denials. And most people think my doctor prescribed this. I don't understand why it's not medically necessary if my medical doctor is saying it is.
And these are people with quite serious health conditions too.
Oh,
We're
100%.
not talking about a rash.
Right.
No, yeah.
I mean,
Usually
The majority of
cancers and-
cancer patients.
Majority are cancer patients, usually stage 4 have tried and failed numerous medications or treatment plans.
And they have an identified targetable
Yep.
mutation and a potential drug
And a potential drug.
that their doctor has prescribed, and they're being told it won't be. And they're all these are very expensive drugs.
Oh, yeah, definitely. And I mean,
Six-figure drugs.
right. And just like the slide said, most of the patients are medium to upper income patients, at least from my experience. And they've been denied treatment, the same reasons Wendy says. And, they're over income for any kind of assistance from the manufacturer of the drug. But yet they're still getting denied the drug from the insurance. So we have to look at it both ways. So sometimes we send an appeal to the insurance company if it's not approved. And then we have to go to the manufacturer sometimes and ask them to make an exception for the patient. Because just because they're over income now, 3 months down the road, they're not going to be over income anymore because they have to pay, $7,000
Right,
a month.
and as you pointed out, if they're even alive 3 months down the road to have
Correct.
the discussion.
Right.
And so these are more upper and middle class patients, which implies that the patients that are underinsured or don't have insurance aren't even in the conversation.
Right.
I mean, they're not getting denied. They're not even getting into the game to begin with. Well, we're talking about access and gaps. I mean, this is pretty fundamental. What kind of frustration do people express about this? Are they angry? Are they upset? Are they confused? I mean,
All
All
of the
of
above.
All the above.
All of them.
Well,
we go-
I had a patient, they had pancreatic cancer. She was in her 50s. They were in California, I think. And had the genomic testing, targeted therapy, and insurance was denying it. It was off-label. They came into us, I submitted an external appeal on their behalf, which was denied, and then the next level was the law judge. So we prepared for that, and I explained to the patient's husband that, what this was, and he was saying, should we even bother? Is it going to work? I said, well, it has worked in the past. Luckily. I said, it's the same thing. We have to prove to the judge, to the insurance, that it's not targeted for, it's not FDA approved for pancreatic cancer, but it is an FDA approved drug, and we have to look for the journal articles and the clinical trial studies. That's why it's important to be in a clinical trial to gather that data. So that we can find that information to support and try to get this appeal overturned. So, and we did that. We presented all that to the judge, and the patient and her husband was there.
you say judge, you mean like an actual court judge?
Right, it's over the phone. It's over the phone,
Oh,
but
okay.
it's an actual,
Administrative
we
law
have to
judge.
raise our hands, and I'm like, it's over the phone, okay? But you do it, And the judge, there's witnesses, the doctor was there, the patient, her husband, I was there. So we all gave our testimony, and bless her heart. I mean, she told hers, they were very teary, and they asked how long this would take, and the judge was very kind and said, I will do this as quickly as possible. And the patient said, I will hold on. And she said that a couple times in other conversations. But ultimately, it was approved. That was wonderful. And I had emailed the husband to see how she was doing, and the patient emailed me back and said, I'm doing great. I feel better than I have in years. So that was really, really wonderful, and it proves that we got to keep pushing. We got to keep doing this, because sometimes it works.
Well, yeah, and again, I'm struck by the fact that, I mean, those patients who get to you and have that kind of intervention and that level of knowledge and navigation always benefit. Even if the drug ultimately doesn't work, they're still benefiting from that. Right. But then I'm thinking about all the people out there who don't have that and who are trying to deal with a system where they pretty much don't have a chance.
Right, right, right.
And, you know, that's where I come down on that in a lot of ways. Another thing that really strikes me is, you know, we hear from Mark, and I actually am from Philadelphia, which is a remarkably sophisticated medical community. And people in those areas, particularly urban areas, even sometimes people who are underinsured or not as well insured, tend to have access to very, very high levels of resources, whether it's genomic testing or genetic counselors. But there's a lot of people in sort of more rural and underserved areas. I mean, I was just listening, NPR is doing a series about the number of rural hospitals that are simply closing. I mean, they weren't particularly well staffed or well equipped places, but they're not there at all now. So how do you deal with the patients who simply don't have access to resources? I mean, they don't have a genetic counselor, they don't have a clinical trial that's, you know, less than 500 miles away. How do you talk to those patients?
You have to get creative.
Very.
You have to get really creative. I come from a very rural area, 400 population, no stoplight even now.
Where's that?
In Kentucky.
Okay.
Teeny tiny town. So I'm really familiar with those challenges. You know, the closest hospital is an hour and 15 minutes either way. And for us, you know, in our role at PAF, a lot of times it's kind of having a frank conversation with them. And I've also found that people in rural areas tend to be, a lot of people, especially the further south you are or west, kind of have the attitude of you don't challenge your preacher or your doctor, you don't want to leave them, you don't want to make them mad. And so a lot of them aren't really receptive to getting a second opinion until you give them all the facts. You know, this is what's out there. This is beyond, you know, the capability of your oncologist that comes to your clinic one Thursday a month. And, you know, you're entitled to those things. You're entitled to get a second opinion. And in those cases, we have to get really creative because usually there's a lack of funding, a lack of resources financially for them to be able to travel and stay, and or even, you know, insurance approval to get that second opinion. It could be an out-of-network facility. There are a lot of factors that go into rural healthcare, getting healthcare for people who live in rural areas, I should say. You know, whether that's, and sometimes we have to get, you know, travel resources, get them on a plane, get them, you know, charitable tickets and lodging and
lodging for their family.
And you do all that?
Yep.
Yes.
Yeah.
Sure do.
I mean, it must, you know, it's hard enough if the nearest hospital's 200 miles away, but if you get a second opinion and that means another 200 miles, that must make it a very, there's a lot of, barriers aren't even the word.
Right.
I mean, you know, Mark's talking about very low genetic testing rates at a place where you have a whole center devoted to genetic and genetic research, genetic counseling, clinical interventions. I mean, these are people who don't, I mean, not only is it complicated, the language is complicated, but the accessibility issues are close to impossible. So as we try to think about bridging these gaps and increasing accessibility, we really have to think about the system itself.
And then we do get some immigration, some immigrants that have come in and they're uninsured, or their families brought them to the United States to get treatment, and there's not a lot we can do there except see if they're, you know, if they can get emergency Medicaid to get treatment, that's only to get stable though. So that is a huge.
And then that
huge
Medicaid may
barrier.
not cross state lines to
Right.
get them where they need to
Exactly,
be
'cause Medicaid
for that.
doesn't.
Or if they're on a visa, you risk your visa status.
Right.
So there's a lot of other barriers.
A lot.
Yeah, and I mean, they're very profound barriers. I mean, this isn't, I mean, education is clearly important, but I mean, you really also have to think of the sort of structural and systematic barriers that are really standing between people, and not just in terms of genetics and genomics, but, you know, targeted therapies, really all the sort of state-of-the-art therapies. Does that get frustrating for you as a counselor sometimes? I mean, it's like,
Definitely.
I mean, how do we fix it? I mean, can't, you know, throwing pebbles in the ocean a little bit?
Well, and I look at it, we all do. This could be any of us at any moment. We could all be
Yeah,
diagnosed
definitely.
with something and have the insurance issue, which we will. We
Right.
will
I
have
mean-
insurance issues.
I have a child who, when I was 22 years old, was born with Down syndrome. So immediately they came to me and said, oh, I'm going to do this test. It's going to be very expensive. Your insurance may not cover it, but it's going to let you know. That's all that they told me. Nobody ever counseled me, never ever, to this day. So, you know, I think that's kind of helped me be a better advocate for other people. But yeah, it's definitely a need. The counseling is definitely a need.
Yeah, are there just, you mentioned immigrants, we mentioned rural populations. Are there other people who you feel sort of have cultural barriers to either being involved in research or even getting genetic counseling? I mean, Kellen talked so forcefully about, you know, kind of the fear of information being used against them. Does that ever come across, that people are afraid that, you know, if we find this out, this is somehow going to be used against me, or those are not the people who call you?
I haven't had a lot of calls from people like that, unfortunately. I mean, I have very few calls that come in through that personalized care line that they may have been denied a test just because basically they have Medicaid or they're uninsured, but I really don't have anybody. I don't think we have that population yet.
Well, they're not making the call.
Right, they're not, you know, they're not getting, they don't even know who we are, so.
There have been a few. I've had a few that were, I think because of their history, maybe they had an identity theft previously with something, so then they're a little, I say, paranoid about everything. So they don't want, we used to ask for Social Security numbers, which was just for the death master. We don't do that now, and patients didn't want to give it anyway, and I understand that, but they're like, what are you going to do with it? So,
I'd ask the same question.
yeah. But even just when we're doing our general intake and we ask for income, and I explain, it doesn't matter to us, but if we're looking for resources, it might. But sometimes they're very, very offended because they want to know, what are you going to do with this? So I think even the genetic, they're like, well, what are they going to do with it? Are they going to sell it?
Well, legitimate concern.
Or what? Or, again, I don't want to be a guinea pig, you know. So
So a couple more questions before we open it up. But can you tell us a little bit about the personalized care line? And do people know what that means?
well, it's starting out. We had another similar care line. I've had a few calls where the provider's office, they're calling us. We've got a form with a list of things that we need from them in order to, you know, to start an appeal. Usually, there's a contact person there at the office.
The goal of that is to get people onto these targeted and personalized
Right.
therapies.
Yeah, it's been denied. The medication's been denied for the targeted therapy, so we're helping with that appeal process. But it's getting the word out and educating, and then as we're talking with the providers or those points of contacts, explaining what we do and how we do it, what we need, and just getting that word out for this targeted therapy that's so needed to happen. Does that help?
Yes, no, it does. I just want people to be aware that we do have that as a resource for people. Are there other resources that you can, I mean, beyond what you've named quite a few, but are there other places where people can go to get help with these kinds of issues, or are you kind of it?
know.
Well, we partner with other organizations like American Cancer
Yeah.
Society, and they refer to us, but I think we're kind of unique.
Kind of it.
Well, okay.
Unique
We
in what we
kinda
do, I think.
Which is fantastic, but it sort of shows how much need there is for
Oh, yeah,
Right,
people
right.
to be there.
And again, it's assessing what each patient needs, which, like I said, that huge, under that umbrella, there's so many different levels, and it's assessing and listening to what the patient needs to see where else it needs to go. Does it need an appeal? Do they need help with disability? Do they need help with coding and billing issue, or unpaid bills, or rent because they've had to pay for their treatment? Or, you know,
Do I pay my rent, or do I pay for my
right,
medicine?
right.
That type of-
So even in the midst of all this complicated stuff, and it is ridiculously complicated, how can you help people become better advocates for themselves? I mean, in the process of interacting with them, how do you sort of educate them to speak better for themselves?
I think a lot of it is kind of teaching them the process, kind of, and almost, you know, when we make the conference calls, we try to tell them to take note of certain things, certain ways we do things. This is why we're calling the insurance, or this is why we're calling the doctor, or this is why we're doing this. So they kind of understand the reasoning behind it, so that maybe if it happens again, they're able to, you know, we try to empower them, you know, to assist in future issues, because obviously we will help them no matter what, but it's always an empowering thing when you can help yourself.
Right.
And think
Yeah,
that's a
I mean,
huge-
that's a word that's been stolen a little bit, but I think it's still really important that people do feel that they have agency, that they can be empowered, that they can do something on their own. Because I think frequently the system kind of strips people of that sense that they actually can do anything.
Right.
So you really do try to educate them in how to speak up for themselves, how to have their voices heard. It's really
And
important.
also, there is that mentality where people don't want to do it. They want someone else to do it for them. So we're also educating and empowering, I think, on you can do this. This is your health care.
You can ask questions.
You can do it. I'll show you how.
So with all you hear and all you experience, I'd like to hear from each one of you. If you could just change one thing that would really help patients in this process. I mean, you only get one thing. I mean, what would it be? What would you like to make it possible for patients to have better in the system?
As far as genomic testing or
Well,
anything?
no, just anything, I think. Because it all kind of merges into one big gooey mess.
Gooey mess. I think education, being informed of what your rights are, what kind of insurance you have, what do you have, what does it cover.
Yeah, there's so many people that don't know what their benefits are.
Right.
And these aren't just people that you would think.
Oh, no.
Again, I mean, I just spoke to a nurse practitioner a few days ago who, until she retired, she felt like she listened to her patients all her life tell them, oh, I have insurance problems, I can't afford that, my insurance doesn't cover it. And until it happened to her, she didn't really understand the depth of, I mean, we spent 3 hours on the phone with her insurance company. And when we finished, she's now understand what my patients went through to get something approved because it happened to her. So
Well, we don't make it easy to understand
right.
what's in your
Education is,
yeah, education.
I agree, yeah.
But also sort of preventive education. I
Right.
mean, not waiting until after.
Right, until you're after
right.
you're diagnosed. How about
Right.
before?
I think it should start in high school. They need to have an insurance class in high school, and then in college and grad school.
Medical
and
school.
Medical school, and should have to do an appeal.
No, but you're right, it's such an important part of our lives, and yet we know so little about it until you actually step right into the middle
Even
of
the
the situation.
basics. What's a copay? What's a co-deductible? Or what's your deductible co-insurance? All those things that people have no clue.
Yeah, and there's so many.
And read your policy. I didn't read my policy till
Right.
I worked here. I didn't know.
No, well, but that's not, you're right, that's not just limited to one section of the population.